following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, pregnancy and prematurity. Two experts are here to answer your questions. Now here's your host, Dr. Kathy Moffitt.
Good evening. This is Prematurity Awareness Day, and the news for West Virginia, while better than it used to be, isn't good. The March of Dimes gives the state a grade of D because so many babies born here are premature. The experts say many cases of prematurity may be preventable. What makes a mother high risk for delivering early? How are the babies affected? What can we do to fix this problem? We'll get answers to those questions and more tonight from our two guests. Dr. Charles Hochberg, an obstetrician and gynecologist at WVU who specializes in high-risk pregnancies, and Dr. Mark Pollock, a neonatologist. That's a doctor who takes care of newborn babies at WVU Children's Hospital. If you'd like to ask a question, give us a call. Our phone lines are now open. So Charles, there are many conditions that we know we can prevent for prematurity, and then some that we maybe find unexpected. So how do you approach prematurity or a woman in preterm labor?
The answer is that we know there are so many that are preventable. If we got rid of those as a problem, we'd be able to deal with those that we can't prevent. Those that are preventable are from women who are often too young to have children. We see prematurity in very young women. We see prematurity in older women who are pregnant. But more importantly, it's women who use drugs during pregnancy, prior to them even conceiving, not knowing these drugs would be dangerous to their newborn and to themselves. Smoking is a major problem in West Virginia, and smoking leads to a high rate of prematurity. Poor nutrition are all these factors that can be controlled. So we have an area in which we can actually prevent premature births, and some things we just can't prevent, we'll never understand. But those that we can prevent would make a major dent in the health of our state.
Right. So we've done better with premature babies, but they still have problems.
Yeah. And if we kind of start with the term baby, and you know, there's a magic to that 40 weeks when all the organs, the brain to the lungs and the belly, all are mature and ready to come out in the world. And if a baby is born prematurely, even just a couple weeks, that maturity is taken offline essentially. Right. So rather than finishing development in the quiet of the womb, it's out in the harsh real world. And that's the kind of problems from the brain not being mature enough and then having to continue to develop. The lungs are very difficult to deal with in preemies. The heart may not be ready to sustain life. The intestines aren't. So
you try and get a baby to grow, but then they don't tolerate feeding, and
so it's a constant. I don't want to say battle, but it's a constant challenge to try to take over where nature left off.
Right. Now I understand that our grade today of a D is not maybe as bad as it used to be in West Virginia, so maybe we get a D+, that we are doing better. Just a couple years ago we got an F, is that right?
Yeah, our grades are getting better. So each year we've seen improvement and a decrease in the incidence of preterm births in the state of West Virginia, but there's a heck of a lot of area for improvement. We're talking 2, 3, 4 percentage points higher than other states, even in our union, like Vermont or Oregon. So we have room for improvement.
So West Virginia is 12.9% of births are premature.
Correct.
And you said Vermont, what did we talked
I think
about
it's about
earlier?
9.3%, so that's
9%.
quite a difference.
And the average in the U.S. is a little under what ours is.
12.2, 12.3%. Pennsylvania is about a percentage less than us. Ohio is less than us. Some of the states south of us, I think Kentucky is about where we are.
Okay. And then there are those who get Fs.
There are fortunately for the country, there are only 3 states that earned an F this session: Louisiana, Alabama, Mississippi. Alabama, unfortunately, has nearly 20% of their babies born prematurely. As a country as a whole, 12% is not as good as a lot of other developed countries in the West.
So in Europe and Canada, they do better than we do. Of course, when they have a little more homogeneous population, it makes it easier.
It makes a big difference.
But access and good prenatal care. Worldwide, do we know what it is without? I mean, what is kind of the natural premature rate, like say in Africa or India? Or
It's higher in those other underdeveloped countries.
Yeah.
Well, we call them now developing nations.
Right.
Interestingly enough, because of infectious diseases as one thing.
Right.
For example, malaria is still a great killer, and malaria is still a great cause of preterm birth. Fortunately, we don't have to deal with that in this country.
Well, we just had a case of malaria
certainly
at
did.
WVU,
Yes,
right?
we did, but it was somebody who just came to our country from
and luckily
from Africa.
everybody is doing very well.
So things like that in developing nations are something they have to deal with. Well, Western Europe, of course, doesn't have that
Right.
problem and have a very homogeneous population, and we don't have that.
Right.
So there's room for improvement, and we always look at our numbers and say, well, we'd love to see them lower. And as I said, I think I can't emphasize enough the fact that we have to get out with programs in our state to try to get people of childbearing age to understand that they have a control over this. They have control over the drugs that they take and they shouldn't be taking. They have control over nutrition. They have control over dental care.
Right.
They have control over smoking. And we would see this number dramatically go down.
So we have a caller from Sheila in Wood County. Hi, Sheila. Go ahead. What's your question?
Hi. My question is, does stress cause prematurity? If the mother is stressed or worried.
Right. What about stress? Does stress cause prematurity?
That's a tough question.
You're going to yield. Yes. The answer, if you look at some of the psychiatric literature, that stress may produce preterm births. The fact is, these are all observational studies, and they really are not very well rooted in good medical studying. I will say this: one of the things that are often brought up is about work and exercise being stressful. I'm very stressed at my job. Maybe I should quit working. The answer to that is probably not. There's never been a good study to show that people who do a normal workload, 35 to 40 hours a week, even on their feet for a normal 2 to 3 hours during that time, lifting items which are not over 25 pounds, in any way increases your risk to stress. Sometimes we have to deal with patients that would really like to think of it that way and try to get out of work. But we just had our chief resident who delivered today and worked this morning.
Wow.
Have her baby tonight. So, and that's a day that starts at 7 a.m. or 6:30 and doesn't finish until 6:30 p.m. That's a 12-hour day for our resident under the stresses of being a physician, and she worked till the day she was ready to have her baby. So that's one extreme, but the other extreme is normal work, yes, may produce some stress for you, but it shouldn't produce preterm birth.
We just heard, wasn't there a woman who ran the New York Marathon and then delivered, or women who do?
Yeah, but stress can lead to behaviors that may precipitate prematurity, like self-medication with drugs, either prescription drugs or that have been purchased on the street, poor dietary habits, perhaps taking up smoking to deal with the stress, and all of those have been shown to increase prematurity. So, the answer is probably maybe.
I think some of the things are practical. If a woman is living in a violent home,
Yes.
maybe not being beaten, but a lot of emotional stress, that to me would make sense that
Yeah.
that contributes to all of us not
Right.
feeling as well.
Right.
And certainly now there's some wives' tales that, she was all stressed during pregnancy and she has a high-strung baby and the baby's colicky. I'm not sure we know that there's that correlation, but what about the cost of these preterm? You had mentioned earlier when we were talking about worldwide the cost, and then by lowering the rates, how much have we saved?
Yeah, we've lowered the rate in the country by about 40,000 births of premature births.
A year.
A year.
Yeah.
And in doing that, we save our healthcare dollars about $2 billion a year. So it's very expensive to take care of these babies that are born prematurely. They often stay in the hospital for a very long period of time in order to get back on the right track, and that's very, very expensive to all of us.
Right. And you said today we've had 3 premature babies delivered at WVU, and in the whole United States?
Estimated that on every day, about 1,400 premature babies are born. And that encompasses any baby probably from 23 weeks to 36, 37 weeks.
So how much do these babies weigh?
Well, the smallest survivor that we've had at WVU weighed about just a little more than a can of Coke.
So 12 ounces.
A 12-ounce can of soda weighs, I believe, 390 grams, and the baby weighed 365.
Right. So really, I know I'm often in helping you take care of your babies, but really not even as big as my hand, or about the size of my hand.
About the size, certainly that a baby that you could hold in the palm of your hand, and that offers extraordinary challenges just from the size,
Right.
and our ability to provide the care with the equipment that we have.
Now, when did things change? Because those babies didn't always survive.
It's a combination of things. It's a big change started about 20 years ago with the advent of surfactant, which is something that our lungs make constantly,
Right.
but preemies don't make enough. So we discovered how to make it. And by giving it to the babies, we've been able to make a huge number who didn't survive 20 years ago survive.
And so when you have a woman come in preterm labor, can you get the labor stopped? Does it depend on? I guess it depends on why they're in labor, but.
Right, and certainly we make every effort. We often get a lot of transfers. We averaged about 350 transfers last year from other hospitals in our surrounding area to WVU in order to try to stop preterm birth, and if not stopping it, to have Mark available to take care of these babies, because most pediatricians and neonatologists don't have the skills or don't want to take care of these babies. They're very difficult to manage. So when we get a transfer, we often will evaluate whether we think they're in fact in preterm labor, use medications called tocolytics to try to stop the labor. We usually can delay the labor by 48 hours. During that period of time, with slowing the labor down, we have the ability to administer steroids or other chemicals which will increase the lung maturation quickly on the baby. So if we can get 2 days worth of stopping the labor in order to give these babies medications to increase their lung maturation, and then if labor is continuous and ongoing, we can't prevent it, at least we've given this little kick to try to get their lungs going. So that Mark doesn't have to, he has to deal with it, but it often can make that a little less of a problem.
And we often consult with the mothers before they deliver, and what we tell them is that even though the medications that they prescribe may make them feel unusual, bizarre, too hot, that they are the best intensive care units that can exist. And every day that the baby stays in the womb can knock off 3-4 days of hospitalization for the baby, or make a difference between life and death.
Right. Interesting. So we have a caller, Harold from Tyler County. Hi, Harold. Go ahead. What's your question?
Hi. My grandson was born premature, and he was 7 months, and he's 28 years old now. He has developed a tumor that was in his sinuses and went up through into his temple, and it was removed in Morgantown by a doctor, and they wasn't able to get it all, but they ended up having to take his eye out. And he's going to start radiation tomorrow. And I just wondered, of course, there is a danger of him losing the other eye with having radiation, and his optic nerve is close to that area. So is there a reason that maybe premature would be?
Right, would be a factor. So he was born at 7 months and now he's an adult. Would that be related?
Probably not. For one, tumors such as this are very rare to begin with.
Right.
And with all the premature babies that have been born, certainly just in the last 20 years, we have seen no patterns of late onset disease, cancers, more than the general population.
Now, I was thinking when he started talking about eyes, there certainly are eye issues that preemies get. But even the eye issues of what we call the retinopathy of prematurity wouldn't be related to what this young man now has.
No, what premature babies, again, because they're forced to develop in the real world versus the quiet of the womb, their eyes aren't quite perfectly round, perhaps. So babies who are born premature have a higher risk of nearsightedness, crossed eyes, and there's a problem while the eyes are developing, what we call retinopathy, where the vessels in the back of the eye, rather than growing nice and smoothly from the center out to the periphery, start growing crooked, and that's where the eye doctors keep an eye on it.
So we watch that. We keep an eye on that. Right. So we know that there are pregnancies that are twins, triplets, even more. That puts women at risk for preterm labor. Or?
Sure. Multiple gestations have a higher rate of prematurity. Twins are higher than a singleton, and of course triplets are higher than twins. Assisted fertilization and assisted reproduction has led to more prematurity when one has fertilized eggs placed in the uterus, and there may be more than one or two, then we run the risk of premature births.
And so have the multiple gestations gone up over the years with all the fertility?
Yes, with fertility drugs and with the use of assisted reproduction, the answer is yes. The average incidence of twinning in this country is about 1 in 90 births, and triplets would be 90 times 90, and quadruplets would be 90 times 90 times 90. So you can calculate yourself how frequent one sees 4 at a time or 3 at a time. The fact is, when you do that artificially, you're going to see a higher number. I think that this is always explained to the patients about when they're having assisted reproduction, about how many fertilized eggs are being placed in the uterus and so forth, and the patient should share that information with the doctor about her needs and her desires before a decision is made about how many good fertilized eggs are going to be placed in that. But we know we're going to be running an increased risk in preterm births when we do that.
Well, you often hear they put more in so that there will be a successful 1 or 2. But if you put 4 in, all 4 could
Well, we
survive.
had that wonderful physician in California who's no longer practicing who put 7 in. And this is not cute. This is a medical disaster.
Right.
And it is it's the physician's fault that we run into these difficulties. So there's been a great effort made in the country now for people that do assisted reproduction to get together and lay down guidelines about this so these do not occur. We never want to send Mark, 4 babies, 5 babies, and 6 babies that are born at 23 or 24 weeks that weigh the size of a Coke can.
So we said even though the babies who are early, it's better to have them born where they're going to be taken care of.
Right.
Get them to the center, and then so you're right there in the delivery room. But that has to be a tremendous effort if you know you have triplets or 4.
We've made a great progress in this state to get mothers here. We have a very active transport system, and fortunately, we don't have to, I won't say never, have to go out to get these tiny, tiny babies, 24, 25 weeks, as much as we used to. They bring them up, and my OB colleagues are amazing because many nights we wring our hands about those babies who are 23, 24 weeks, and many weeks later the mothers are still there.
Good.
And haven't
With the baby,
delivered.
baby in unit. Yeah,
in.
good.
And when they deliver, then the babies have most of the time, a relatively short course for prematurity, much less in a way of morbidities or other diagnoses that occur with the prematurity. And that is, and again, that's when we counsel them. It's like, you are in the best place right now. Whatever the docs say, do it.
We don't take care of these patients who are really on the verge of developing a real preemie until neonatology is aware of them being in the hospital and have the discussions about what they may be faced with as a newborn. And I'm reminded of the story about when you transfer these patients. There was a great obstetrician by the name of Alan McLeod, who was the chairman of perinatal medicine at University of Miami when I was at South Florida. He was from Scotland. He had a wonderful brogue Scottish accent, and he used to say, the best transport van is a mother's uterus. Right. And he means, and it's true. Yeah. So we'd much rather take the mother with the baby in there.
Well, I remember when I had my first child, I thought, man, it was a whole lot easier 2 days ago when he was inside. Yeah, right. It is, and I didn't have a premature baby, but yeah, it is better.
Yeah, so we like that we take them here, and we'll do the best we can to keep them in there. We'll make sure they're on the right medications, and of course, having the great neonatology we have the backup. So
now, what about a woman who's already had a premature baby? There is a risk.
There's a significant risk. In fact, we really don't know who's going to have a preemie. The only common denominator we can look at is women who've had a previous preemie have a significantly higher rate of having another preemie. So if you had one premature birth, the incidence of you having a second premature birth is around 25%. If you had 2 preemies, the incidence of you having a third preemie is close to 40%. Wow. So the numbers go up and up and up. And other than knowing someone had a preemie, we can't always predict who's going to have the premature.
Right.
But a previous premature sets you up for another preemie, and we are very cognizant of that and take care of the patients with proper prenatal care to try to avoid that.
So we have about a minute to go. So it certainly seems that it's prevention. It's good prenatal care, good diet, not smoking. We have taking care of your teeth.
Take care of your teeth.
Get your teeth cleaned before you get pregnant so that you have all that scale and you have the inflammation out of your mouth before you're pregnant.
Patients with bad teeth have a higher rate of prematurity, but you cannot take care of them during the pregnancy. Right. They need to be scaled, and that's not just a little cleaning, but a good deep cleaning prior to them conceiving.
And the illicit drug use. I'm just staggered that a woman would think of doing cocaine to make herself go into labor, and that you have a very high rate of babies you take care of women who you take care of with drug use.
Yeah, it's in our state, I think it's worse than some of the other states. Mark commented that we're living through the drug generation now, which was in the 1990s. We're living it here in 2010.
Yes.
Right. So we hope that, so the last report I think was 4 years ago, so we hope in another 4 years that we maybe get a C. We could hope for a B.
Hope for a B.
But we want to continue to see that rate go down, and that would be a good thing. We've been talking about pregnancy and prematurity with Dr. Charles Hochberg and Dr. Mark Pollack. Thank you both for being with us. If you'd like more information, talk to your family doctor or visit our website at wvuhealthcare.com. For Doctors on Call, I'm Dr. Kathy Moffett. Good night and good health.
It's fun. It's only 2.
Join us again next week for an encore presentation of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.